an abrupt hello with the music. I was getting into the mood. It was really, really nice. And I hope you enjoyed it as well. My name is Magdalena Dakar, and I'm Chief Executive of FH Europe Foundation. And I am absolutely delighted to be joined by a wonderful panel of international speakers joining us literally from around the world for this very special webinar. This webinar, it's our first in a series of 4 webinars before FH Europe's annual meeting, which will take place this year on the second weekend of November in Amsterdam. And the theme throughout all those webinars is unmet needs from different perspectives. It is a very hot topic right now in Europe, and we will be addressing that specific topic while discussing still an ongoing issue of FH pediatric screening. And the title of today's webinar is FH Early Screening Saves Lives, is cost effective, but is it enough? With me today, joining us, we have our young patient ambassador, Indy Bangma from the Netherlands, Professor Albert Wigman from the Netherlands, and I'm sure a lot of you know both of them already. Joining us from the UK, Ms. Kanika Darmayet, and all the way from Australia, and it's 3 o'clock in the morning for her, it's Professor Zanfina Ademi. And then we have Professor Ivan Pecin joining us from Croatia. And last in the panel, but extremely important to me, our own and only Gergely Jambrik, trustee of FH Europe, but also a patient and a parent to a child with FH. Without further ado, I would really like to kickstart because we have a packed agenda. Some housekeeping rules for today. This meeting is being recorded, so don't worry if you need to step out or if you would like to share it after this webinar. We will be disseminating the link. If you would like to ask any questions, please pop them in the chat. We have with us Emma, our community engagement manager, who will make sure that we don't miss any of those, or you can as well pop those in the Q&A section. We might not be able to answer all of them tonight, but we will do our utmost best. And finally, please do not share, if you're a patient, any sensitive information about your history of your condition. If you like to ask any questions, you can always reach out to FH Europe Foundation through our website and dedicated email. With that, really, I would like to bring in first Indy. We will keep this discussion today very lively, and it will be very low on presentation, but more on shared stories and discussions between our panelists. Indy, you are one of those people who was very lucky in a way because you were diagnosed early in your childhood, and your story is a little bit different than the story of a maybe average FH patient. I would be keen for you to share with everyone shortly your story, but also what it means to you to be identified early and what it means in terms of unmet needs. Any call to action from you, because in a way you are an aspirational, it's an aspiration for everyone to be identified early. Indy, over to you.
Thank you for the introduction, Magda. Good evening, everyone. My name is Indy. I live in a small village in the Netherlands called Uitgeest. That's 30 minutes away from the capital city, Amsterdam. Since a year, I'm a proud ambassador of LEEF. That's a patient organization of FH in the Netherlands and also of FH Europe. And my goal of being an ambassador is to get more attention for early screening and to talk to young people with FH that you don't have to worry about having FH. I really enjoy these tasks as an ambassador, and I hope to get the attention from a lot of people to reduce cardiovascular diseases at a young age. Because I have FH myself, I tested positive at the age of 8 years old, and my father also has FH. My granddad got 2 heart attacks at a young age, and his father also died of a heart attack. But in that time, FH was not that well developed as it is now within the research. So after the second heart attack of the father of my grandfather, doctors thought it was FH because my grandfather knew there was something in his family. Finally, he got tested in that time, and he got FH. And my father was also tested. He was 18 at that time. And he also tested positive. So now I am here also with FH. I am really lucky that my parents tested me very early because it's important to prevent those situations like those that happened to my grandfather. I am raised with the thought that I have FH, so I don't know different. For example, when I was 8 years old, I was at primary school. And I had a party from a friend. I only ate chips or cake and not both. So I am used to it, but I can imagine for people that who got tested late, it can be different. I don't feel like a patient, and I also don't like the word patient because I just don't feel like it. I take rosuvastatin and Acetrol every day. And I don't have any bad experience from it. I can do everything I want. I can go out with friends, go on holidays with my family, and the most important thing for me is to play sports. I play handball 6 times a week, and it's the best thing for me. It's literally my whole life, and playing sports is, of course, the best thing to do when you have FH. I never experienced disadvantages from having FH, but I'm really worried about people that don't know it. I want everyone to test early and want to be safe because the treatments are so well developed nowadays that you don't have to feel like a patient. Once a year, I am tested in the UMC in Amsterdam. My little brother also has FH. So we always go to the hospital together. I really like to go to the hospital because we have the best doctor in the country, Albert Wiegman. Unfortunately for me, he is getting retired this year, and it sounds a bit weird, but I think that I don't feel like a patient. And after my secondary school, I want to study medicine because for me it's really interesting and I want to help all the people with FH. Thank you.
Oh, indeed. I was actually far more emotional than I thought when you said that you're being managed by the best clinician in the world. And I have to echo this. I really love Professor Albert Wigman, and I hope that the way he has been dealing with other children can inspire other clinicians around the world to do just that, because he always gives a specific tip. I mean, actually a set of 5 tips for anyone who has got FH. Can you repeat what those are?
Do not smoke. And these times also vaping, because vaping is really upcoming under young people. Play sports, of course. Take your medicines every day when you brush your teeth. Just take them. It's a routine. It becomes a routine, and always look to the left and to the right when you cross the road, because otherwise there's still no chance that you can become 100 years old.
So that's the promise of Albert Wigman to all his patients, that everyone who is being diagnosed early and will adhere to those 5 tips will live up to 100 years. Fantastic. So tell me, Indy, one thing I would love to understand from you is you are a different generation of people who are diagnosed early. Is there anything specific that you could share that could help us really activate some of the policymakers, medical societies, to make screening a reality? From your perspective, younger people, what would be your sort of ask to, or maybe message to say, you know, if you could help them understand that sooner is better and it's actually not a burden to you as a young person?
Yeah, like I told, there are really negative aspects on it when you know it later in your life. And how earlier you know, there can be much more to do. Like I take 2 medicines every day, and like for me that's nothing now, but maybe when I knew it later, it would have been much a way, how do you say, then there would be other things that happened to me, like a heart attack or something else that I got. Like now, I can be 100 without having disadvantages of it. And I want that for everyone, because my story is really good. But I also heard other stories of young patients, also with the homozygote variant, and you don't want to happen that, because
Absolutely. Absolutely. And you know
so
what, Indy, I think what you shared is based on the story of your family when there were tragic events early in life of your family members, and then comparing your very positive story. It's really our aspiration to make it a reality for people across Europe, because everyone deserves the same opportunity to health. And I just wanted to sort of build on that and bring this amazing clinician you were talking about earlier. He's with us. Professor Albert Wigman is joining us tonight from Rome. So thank you, Albert. You've got decades of experience and generations of families who have been your patients. But luckily, you mentioned in preparation to this webinar that with every generation, you identify people earlier and they live better quality of life. I would be keen to hear from you as a clinician, as a researcher, but also as a person who's seen so many people in your life. What are the unmet needs? What do we need to do to make FH screening a reality? What else do we need to do to make it happen?
Thank you for the invitation, and thank you, Indy, for your brilliant way of telling how the story is. In that past 30 years, I saw 4,000 children with FH, and they are all now, the oldest is now 50, live and kicking without any problems, because they started early and it was not a problem for them. That's the most promising message to the world. If you detect early, you don't become a patient. As Indy says, you become a healthy person with a small problem, and that small problem is resolvable. And that's the message to all pediatricians, but not only pediatricians, to patients, to all the politicians. It's easy to detect, and it's easy to treat without a lot of problems. Indy said it fantastically. Don't smoke, eat healthy, exercise, take your tablets, and look to the left and right when you cross the road, and you will become 100. And in the past, this was definitely not the case. We did an investigation in parents who started at a mean age of 32, and children who started 2 decades earlier. And we published that in an international journal, the New England Journal of Medicine. And we saw that in the parents, 1 in 3 got a heart attack before the age of 40, whereas none of the children had any heart problems. And 11 of the 156 parents already died before that age, and none of the children. So that's something. And recently was published that in 56 countries, the mean age of detection is 44, and that's far too late. The mean age of the parents in my outpatient ward is 38, and the mean age that they die from it, luckily not all, but if they die at a an age around 44. So we should be detecting them earlier. And I'm Sanfina Ademi really thankful that she helped to see if it's cost effective and cost saving, and she will tell a lot about it. And it's not my piece of cup of tea. But it's important to know that it is it's doable, and it's helpful to prevent. We did ultrasounds of the carotid arteries, and we saw the plaques going to vanish. So if there were plaques and not calcified, they will vanish.
Professor, and I apologize, I keep switching between Albert and Professor, but because I've known you for so long now. Professor, if it's so successful, so effective, and it can really give people's bring back the quality of life and extend life, why is screening not yet generally implemented across Europe? I mean, we will hear in a second, and I'm just giving it away a little bit. It is cost effective. It saves life. Why is it still an issue?
Yeah, that puzzles me as well. So Norway is doing really well. Czech Republic is doing really well. But what I nowadays see, those countries that had not that cascade screening, when one person was detected, you test the others in their direct relatives, first degree, second degree, third degree relatives, and we were successful in that. But for instance, Slovenia and Croatia and Ireland and Cyprus do nowadays universal screening, try to find the children at a young age, the age that they are treatable, because nothing is in their vessels calcified. As long as it is not calcified, it can be removed, the fat in their vessels. And that's the idea. So I encourage that. It's a matter of you choose for one or the other direction, but you can't choose for no direction because you don't find them early enough.
Professor, absolutely. And what you just said right now offers a fantastic segue to the first of presentations this evening. And this will be some of the available data by Kanika Darmayat from EASFHSC, so the global registry. Kanika, so lovely to have you with us. We know that there is exciting data coming out, but it's not yet published, so I understand that you will share with us as much as you can. But your message is important in terms of understanding pediatric situation, the landscape, what happens when we screen, what happens when we detect, the age of children being detected, and what happens if they're not early identified. Kanika, the floor is yours.
Thank you, Magda, for this kind invitation. And yes, as mentioned, I will be presenting some of the work that I have undertaken based on the FHSC registry. Oh, that's not it. There we go. And I will be, and of course, due to the time constraints, I will not be able to present everything, but please do look out for the paper, the publication, when it is published very shortly. So I guess I wanted to sort of follow on from what has been said, and just again focusing specifically in childhood, but using real world considerations. So using real world data, so routinely collected, that is part of the FHSC registry, and how do we make sense of all of that to help inform screening for FH early in life. So to follow on from what Indy and Professor Wiegman just said, I kind of wanted to begin by stating that FH is highly prevalent, but in terms of quantitatively, we've seen that actually it presents in 1 in every 311 individuals. So that means that there's more than 25 million individuals worldwide with FH right now. And if we don't find them, then these 25 million individuals will remain unidentified. And a recent call to action actually did find that worldwide, only less than 10% have been identified of individuals with FH to date. So that means that 90% of those 25 million are still to be found. So again, just following on from what Indy said, the aim of FH care is early detection so that we can begin early treatment. And that really is demonstrated very nicely in this figure, where we see that individuals with FH, shown by the red line, we can see that have much higher levels of LDL-C compared to those without FH, so the general population. And if we consider the threshold of 150 milligrams per deciliter as a threshold that would lead to a cardiovascular event, we see that this threshold is reached at 35 years of age in individuals with FH compared to 55 years of age in the general population. So if I can bring your attention, if we identify FH or screen for FH early in life, so let's say 9 years as shown here, we can effectively redirect the life course trajectory of these individuals with FH to now mirror or reflect that of the general population, whereby the threshold is now reached at 53 years of age. And again, as Indy mentioned, that if we identify actually FH early in life, we can actually promote healthy lifestyle habits, as evidence shows that adopting healthy lifestyles early in life do actually continue into adulthood. And of course, the other added benefit is that when we identify early in life, we can in fact start those individuals on much lower dosage of treatment, which potentially will lead to, which again, evidence shows leads to better adherence rates. So as mentioned, that worldwide, there's more than 25 million individuals with FH, but less than 10% have been identified. So to help improve the aim of FH care and help improve and identify FH early in life, but also those 90%, we've created here the FHSC, so the Global FH Studies Collaboration Network and Registry. And this network and registry really provides a unique opportunity to inform health policy at both national and international level. And so far, we have participation, or 74 countries participating in this initiative. So taking all of that data that has been gathering from 2015, my objective was to characterize the children and adolescents, so those less than 18 years with FH in the registry. And what I wanted to explore was, what are the characteristics of those identified children and adolescents? So how do they present? And then specifically, what ages are they being identified? So it's important to sort of have these understandings using real world data so that we can begin to have identify contemporary approaches to help find FH in childhood, especially as now more of we're moving towards policies for screening for FH early in life. So in terms of the methods, we had data from 48 countries, which included just 11,848 cases of children and adolescents with a probable or definite diagnosis of heterozygous familial hypercholesterolemia. So the first set of results I wanted to present are the baseline characteristics, where we see, so what are the characteristics that these children present with when they are found to have FH? We see that in our data set, we have a good equal distribution or representation of both boys and girls. And on average, they're being diagnosed at 9 years of age. Interestingly, we see that the presence of coronary artery disease is very low. So this provides an enormous opportunity that if we find FH early in life, children are disease-free. And if we then initiate treatment early in life, because we're finding them early in life, we can effectively make sure that they remain disease-free and prevent any coronary events from ever occurring. So in terms of finding FH, there's classical signs such as corneal arcus and xanthoma that are used to help in identifying, screening, or diagnosing FH. But we see in our data set of over 11,000 children that the presence of these physical signs is very uncommon. So this means that we're going to be reliant on other factors to help in determining FH in childhood. So we next looked at LDL-C levels. And here we can see just how much higher the LDL-C levels are in children with FH, so not on any lipid-lowering medication, compared to those non-FH children. So this effectively shows that when we want to find FH in childhood, we're going to be guided by LDL-C levels and not the traditional signs that we were so reliant on to help us diagnose in prior times of corneal arcus and xanthoma. So we next looked at how the LDL-C presents across ages and by boys and girls. And we can see here clearly there is a clear difference in LDL-C levels between those that have FH across both genders versus those that do not have FH, as denoted by the blue line. So this tells us that if we measure LDL-C levels in childhood, we can have a pretty good understanding that if that individual or that child has FH based on the LDL-C levels, because we can see that there is a clear difference even at the 5th percentile. So this potentially provides an opportunity that can be potentially used by clinicians to help in identifying when they measure LDL-C levels in childhood, in children, that potentially they can use these percentile curves to help determine, to risk stratify the children for further testing. So that was a very brief presentation of summarizing some of the results, but overall I would like to thank Magda for this kind invitation to present this data, but importantly all the FHSC investigators and collaborators and the individuals with FH that have contributed to the registry and to our work. Thank you very much.
Thank you so much, Kanika. And as always, it's fascinating to see all the evidence. And I really appreciate how you help us understand sometimes very complex research that happens behind the scenes and translate it into very understandable messages that can be taken away both by the medical community, but also by patient advocates, maybe parents of children, to really help them understand how important it is for those children to be diagnosed as early as possible. Because as you said, they won't develop the condition, they won't develop any signs of your classical CAD, and they can probably live a normal, fulfilling life, just like Indy. And potentially you might have noticed Indy disappeared because she had to go to her sports training, because she can continue with her happy, normal teenage life. So this is great. But Kanika, I am still puzzled. You've been having those presentations with us for close to 2 years. And we are bringing this message to policymakers to convince them about the importance of screening. And still, we've created a movement. It's happening, but it's, you know, from a patient advocacy perspective, I feel like it's not happening fast enough. There are so many children to be saved. And I just thought, maybe the answer is in cost effectiveness. Maybe if we use another argument, it will speed up the process. And I could not be more thrilled to have with us Professor Ademi, as I said, joining us all the way from Australia, 3 o'clock in the morning. What a dedication. Zenfina, I'm so keen to hear from you. Is it really cost effective? And if so, can we actually earn out of screening? Over to you.
Thanks, Magda, for the invitation. I feel very honored and pleased to join this webinar, and hello to everyone. I'm going to present some of the results with Dutch FH screening, which we did together with Professor Wigman and other collaborators. So I just wanted to touch base, first of all, when we think about FH screening, to sort of highlight that I'm thinking here about heterozygous FH, not homozygous FH. And when we think about economic case, we think of 2 aspects. Obviously, it's identification and diagnosis, but also then management of it. How do we do management? And we know that statins, and as Indy pointed out, are cornerstone of primary prevention of cardiovascular disease. So Dutch FH screening started in 1994, which was supported by the Ministry of Health, and actually a program was implemented to identify people of all ages, not only children. And also through this program, around 11,000 children were cascade screened by the year 2016, and of whom 50% of them were identified to have a mutation positive. So when we look at the total investment of this program, according to the data we have so far, so Dutch Ministry of Health has spent around 10 million to implement this project countrywide. So we were interested to know, when such implementation have been in place, was it cost effective? And Netherlands, it's a great example to test that. So in 2017, I started to work in this project with Professor Wigman and other collaborators who I've highlighted here. We were trying to answer the question, how can we move more from reactive to preventive healthcare. And some of you here in call, we know that clinicians or how the treatments have been reimbursed currently is majority of the new treatment are given positive go when you have a condition. For example, PCSK9 inhibitors are mostly used in people who already have a coronary heart disease. So that's why we wanted to sort of shift the conversation. Can we move more from reactive to preventive healthcare? So after 6 years of work, we finally published our first paper in JAMA Pediatrics, looking at cost effectiveness of Dutch FH screening. So when we look cost effectiveness, it's a little bit complex. Data comes from different sources. So we have to establish quite clearly the population. And in this case, with children aged 10 years with a heterozygous FH, we were interested to understand whether early screening and treatment with statins in majority of the patients, because some patients had PCSK9 inhibitors and other additional treatments, and we compared to usual care. And as been mentioned today, majority of people get identified at age 45, and only 50% of them have the actual desired treatment outcomes. In health economics, usually we measure quality of life, healthcare cost, but in the case of Netherlands, we look also at productivity costs. What means to people in terms of returning for them to work? And usually when we do health economics, we don't only look within 1 year. We want to look over a lifetime, over a lifespan, what happens to them. So this is sort of just to give you a background. So people go through screening. They either go through intervention, screening, cascade screening and treating with statin, or usual care. So later identification and later statin treatment. And obviously we would like to portray the biology of the disease when we sort of look, what is the likelihood of these patients to have heart attack? And what is the likelihood of them, while having heart attack, dying from heart attack and dying from other conditions? So this is just to give you an overview, the complexity of the model. And usually when you build a health economic analysis, it's like building a Lego parts of the sculpture, because you have to actually amalgate all the data from different sources. And usually they come from clinical trials, real world registries, as Kanika mentioned, but also from statistics as well. So here is some data inputs where we have to know what is the age of starting with treatment, what is the likelihood that somebody is treated for how much we would reduce their LDL-C, their cholesterol levels. We are interested to know about their quality of life, and then we are interested to know about the cost to the healthcare. So this question, does cholesterol years matters for FH and atherosclerosis? Definitely yes. So current evidence that we have and we use in every economic model significantly underestimate the benefits of existing treatments and new therapeutics. So inclusion of cholesterol years significantly improve prevention and allocation of resources for FH and generally for cardiovascular disease. So just to give you an example, so for example, if you would take your medication 70% of your time over 50 years, it's much more efficient than taking it 100% for only 1 year. So this is how it's important for you to actually have control cholesterol level over a lifetime. So these are the results of our study, which we showed that if patients start at age 10, and then when we look their cholesterol levels, so those who are treated early, they have much more nicer, flatter LDL-C levels in comparison to usual care. Also, what we show that when we start treating them early, and has been pointed out by Albert Wigman and Kanika, we actually save around 5 years. So people shift, so they live 5 years longer if they are treated correctly. And what does it mean in terms of cost effectiveness? So for Dutch perspective in this case, it was cost effective from a healthcare perspective, but what was more importantly, it was cost saving from a societal perspective when we actually include whether patients return to work and impact on society. But is efficacy, effectiveness, and cost effectiveness the only parameters that government look for the implementation? So the answer is no. They usually look at the total cost. How big is the disease that we are going to treat? So that's why in the case for cascade screening in Netherlands, we actually did return on investment as well. So what we showed is that for every dollar that the Dutch ministry has implemented to early detect and treat these children, returned government 8.3 euros. That's a huge return on investment from a disease that actually started very early, but it actually been able to save government by patients not going as much to see clinicians, but at the same time not having heart attack, because those costs to the system are quite high. So in conclusion, so this finding of this study suggests that early detection and treatment is cost effective and cost saving. And as I pointed out, we have a return on investment of $8 for every dollar investment. And also our results are crucially important as atherosclerosis starts at birth, and childhood is an important period for screening and prevention. So just wanted to highlight out that recently we have done systematic review of all possible screening strategies for FH. And what we found out that majority of the screenings that have been done, either cascade screening, opportunistic screening, systematic screening, and population-wide screening has been cost effective. So here, just wanted to show you our study for children, and the same one that we did in Australia showed that how inclusion of cholesterol years or treating early in life has a tremendous impact on actually showing the trajectories that these patients actually benefit the most, but also it improves precision and decision making. So in conclusion, so you can see that majority of the screenings that are available to us are cost effective. But we also have to understand that not only one screening is going to answer all of our questions. So we have to actually elevate all our forces to guide policy decision makers, which potential screening would be the best for specific population. So sorry, I rushed a bit here, but thank you for having me, and I look forward to any of your questions.
Zanfina, it's been incredible, and I just been getting messages on my phone saying how useful, clear, and finally resolving so many questions this presentation has been. So thank you, and I am so excited that you will be joining us in person at the annual meeting in Amsterdam, because we want to bring that message, that lesson, to the wider population of patient advocates fighting for implementation of screening programs. And what I really enjoyed is the fact that you said that there was no one model that is going to resolve everything, and we need to find the very bespoke approach for every country. But bottom line message here is that it's cost effective, and not only cost effective, there is actually return on investment, and that should excite any policymaker and politician and a budget owner. Not only they do something for the nation by guaranteeing access to health, but also a return on investment. So we will hopefully have the time to address some of the discussion points. But I wanted now to build on what you said, because joining us from Croatia, we have Professor Ivan Pecin, who actually successfully managed to convince key stakeholders to make cholesterol testing a reality in Croatia. And I would love to hear from you, Ivan. How on earth did you do that? How is it going? Any lessons learned? Over to you.
Dear Magdalena, dear all, so thank you very much for the opportunity. So I will speak by my heart, because some of you I just have the opportunity to see for the first time, and some of you here are responsible for the Croatian success. So first of all, as I said, I have 7 minutes for 7 years. So it was very easy, because the first person is Professor Željko Reiner. You know him, he is the famous lipidologist. He is my teacher. The second expert that infected me by FH is Professor Steve Humphries, that I had the opportunity to work at the University College of London, took the first samples and do the PCR and everything, genotyping Croatian samples. And the third one is present here. He's a cherry on top. He's Professor Albert Wigman. So I think it was in November in 2015, and I was the participant of the European Society of Atherosclerosis School in Italy. Professor Guardamagna invited me, and for the first time I saw the presentation of Professor Wigman, and I was infected. When I came back to Croatia, I talked to my boss, and I was, a bit younger, and I said, we have to do the screening in Croatia because it's a benefit. We don't do it. And little by little, the story about FH started in Croatia. So to be honest, we started hard work maybe 8-9 years ago. First of all, we started, because I'm now talking in front of Croatian Atherosclerosis Society, that I'm the vice president, and also we are the referral center for the rare and metabolic diseases. And we took from our colleagues, cardiologists, patients that survived myocardial infarction, that they were diagnosed of the myocardial infarction, put stent, so some of them died, but some of them that were alive, they were transferred to my lipid clinic. And then we run them through the Dutch lipid scoring system. We identify the probands and do the cascade screening. So those are the first patients that we managed to find with the FH, because till that time, maybe detection rate was about 1%. So from the 2015 to the 2023, we were talking about FH on every single levels, in the primary physicians, on the cardiologists, on the neurology meetings, in front of all other stakeholders, in the Ministry of Health. So it was very easy. It was easier because my teacher, Professor Reiner, is also, he was the vice president and the president of Croatian Parliament, right? And the former minister. So it was maybe easier to do that in Croatia, to be honest, right? And then in the 2018, PCSK9 therapy was available in Croatia. So we started with the PCSK9. And then we were just starting up with the story of an FH, and we were just, thinking of, let's do the screening, and then the COVID came. So we were blocked maybe for 2 years. And it was unfortunately because during these 2 years of COVID, Croatia had the opportunity to take the steering wheel of the European Union, as Slovenia has now and Hungary will have. So we lost this opportunity by COVID. But at the end, we said globally, and in Croatia, we did everything for this stupid disease, for the COVID. So just, put the focus on lipids. And we were starting to think more about the lipids, and in front of the Croatian Cardiological Society and Atherosclerosis Society and the Croatian Society of Family Physician and Biochemistry Medicine and School Medicine, we developed the proposal for the national plan for the early detection of the FH in Croatia. It was named 2021-2031, so in the next 10 years. And of course, it was presented on all levels in the Ministry of Health and in the National Insurance Company. And at the end, it was approved. It was approved, and you know that this spring, finally, we started as a national screening. So when the children go for the examination for the school, it was traditionally that they only do the blood count and the urinalysis, and from this spring they also do the cholesterol. We took in this spring around 80% of the population, school population. So it's around 30,000 children, first grade children. We hope, because it's a national program, it's obliged to do cholesterol, that we will screen all 39,000 first grade children that enter into the system. So the preliminary data show two things. First of all, because the obesity and the very poor bad eating habits, more than 10% of children have total cholesterol higher than 5.1. And around 1.4% of them have higher cholesterol, total cholesterol, than 6.1 millimoles per liter. So we already found 500 of children in Croatia in this generation that are highly suspected to have FH. Of course, now we are developing other things that we will also inform, and the parents and all, everything are just waiting for an FH child to be detected in Croatia. This September, the first year started, so the first children detected started going to the school, and we also put all efforts to the public campaign. So you probably heard about our Run for FH.
We cannot very well see, but we will make sure that people know about it.
Yeah, maybe yes, maybe not. I have the T-shirt that was diagnosed. So we ran for FH, and the 1 month before the 24th of September, we had beautiful weather in Croatia, and it is already 3 weeks after the World FH Day. But in this Sunday morning, it was 12 degrees, it was raining, it was blowing, and it was like, end of the world, because the nature said, we will fight. And 200 participants were there, and we managed succeed to transfer the awareness, to increase the awareness about the FH. This is the first thing. The second one is I will put it on this way. I would like to present our newborn. I saw here in the participants that Eva is with us. So she will be the president of our organization, patient organization. And please, I would like to ask you kindly that you take a good care to our Eva in Amsterdam in 1 month. Okay, so please promise me that you will take care of our newborn Eva, because she is, I think, the youngest member here in this community. And after this public campaign, we also do rock concert for an FH, so we call it Rock for FH. And so we are now just to make a long story short, as you can see, everything is because of the enthusiasm of us, right? So the Professor Wigman is enthusiast, Magdalena also, Professor Ademi. Well, it's now 3 a.m. and she is talking with us, The Gerli also, Kanika. So we are all enthusiasts, and because of us, we are making things work. And we will do it, more and more. And I'm really, happy that we started, and I won't, let the lipids go. So
fantastic.
It was by my time.
Absolutely. And we did warn all of the clinicians who are used to giving slide presentations that this is not going to be your traditional webinar with slides. We want to really engage with you as people. And Eva is saying hello from Croatia. Eva, wonderful. We look forward to you, to meeting you in person, and obviously all the efforts that led to now a creation of a national patient organization. And so what you have described, Ivan, is pretty amazing in a way that it was a long process. It took maybe, I will say, a group of mentors who mentored you over your career and inspired you and helped you become a champion on a national level with your colleagues and your supporting circle in Croatia to make it happen. But what really struck me is the fact that you have systematically engaged with different stakeholders. So it was really collaboration, networking, and engaging critical healthcare providers to convince them, and to make it happen. However, it was led by clinicians, not by patient community, which is slightly different compared to other countries. And yet again, this is a different model of making things happen, right? So we need to recognize that.
Maybe I can comment on that, because I also do the rare diseases. And the problem about the rare disease is also a big problem worldwide, and everything is about the awareness. And I have lots of connection with the Croatian Alliance of the rare disease society of the rare disease. So I just copy paste the model from the thing that I do in the rare diseases to the lipids. And I will once again comment by heart. On every single webinar, I'm more and more smarter. So some of the messages here, for example, the data that showed Professor Ademi or Kanika, it makes me smarter and stronger, right? Because I know it's a cost effective. I know the numbers. So I think that we are still learning. We are still all learning. Maybe someone from this community and neighboring countries will learn also from my story.
Oh, absolutely. And you know what, as a chief executive of FH Europe, I'm always amazed that patient community is absorbing, learning, connecting, but also teaching. And you are now the second leading clinician that I hear from that you've picked up something from our activities, which is fantastic. And next year, when there is a run for FH, I want FH Europe to be partnering with Croatia and do a joint, maybe even virtual run, internationally. With that, lots of enthusiasm. I would like to move now to our last speaker, Gergely. Gergely, you know why I brought you to this panel. Hungary will be leading the EU presidency in just a year's time. And there is an opportunity with all the momentum created, with the data, with the information, with the evidence, to try and push for implementation of improved screening and early detection, so that not only Hungarians, but also European community can really benefit from all the knowledge that we have in place. You co-leading a patient organization in Hungary. You are now as well leading FH Europe. I would be keen to understand from you, how can this help you advocate from a patient community perspective? And if there are any other needs that you have that haven't been unmet to really help drive this positive movement. Gergely, over to you. Gergely, we just need to make sure that we can hear you. Thank you.
So hi everyone. So my main message is basically that FH does need to be addressed, and not in words, not just in words, but in action. That's the main message. And that means action of the EU, action of the states, the individual member states, and the individual states also outside the EU, the civil organization like FH Europe, and also action of the parents and action of maybe the children themselves, if we teach them, if they understand, of course, on their understanding level, what needs to be addressed, what needs to happen. And I guess we do have the evidence. We have seen medical, statistical, economic, and even a new countrywide proof of that it is cost effective, that it is also returns the investment. So I guess we lack the understanding somewhat on EU level, and also on especially on national levels, that this would be very important. And it's many times much more important than addressing the actual heart attacks, the cardiovascular, the already developed diseases. We can simply say prevention, but if we go deeper a bit, prevention means that people stay healthy or almost healthy, and they don't get severe diseases. They don't leave working days out or even months of work out, and they of course don't die. So actually my personal vision is basically that FH should mean nothing more and nothing less than it means for Indy. So she is living, first of all, she lives a happy life, she's sporting, she even has fun going to the doctor, because it's not a depressing thing that they have, let's say, re-engineered my heart several times because I have a fatal disease. She just picks her medicine, and she understands what's happening, what's her condition, and there are doctors identifying her and caring about her. So I guess that needs to be addressed, and that's what we need basically: awareness, doctors who identify, and also states and civil organizations who actually care about this condition.
So, Gergely, now you have just listed all the potential ingredients for success. I hold you accountable, together with the community in Hungary, to advocate exactly this way when we meet in December in Strasbourg at the European Parliament, and then later on in 2024 to really advocate for screening for Hungary and for other remaining countries. Because as a parent to a child with FH, you agree that every child deserves to live a life like Indy, which is normal, happy life.
Exactly, that's our main goal for the near future. And let's say if politicians and the state declare something as an important goal, then we can or should count on that, and should
I will hold you
push for
accountable.
that, and should let them remember what was the promise, and keep up the promises and keep pushing for that, and again, as I said, not just words but action. I mean, accountable action and verifiable action.
Absolutely, absolutely. Thank you so much, Gergely. And I know that we are approaching end of this webinar in just 3 minutes, and I can see so much now happening in the chat. Some updates from Slovakia and a few other countries I've seen, and a lot of words of appreciation for the presentations. I can see as well someone's hand up, but if I can just suggest that maybe you pop your question in the chat, and we will try to ask it if we can. I would love to, in the last 2 minutes, really summarize what was happening and ask everyone for a short key message to say, is the fact that that screening early saves lives and is cost effective enough? And if not, what else do we need to do? But I've heard so far that we have the data, we have the evidence, both through a lived experience on side of Indy, Professor Albert Wigman. We have very, very clear numbers from the registry, as well as from the health economic studies. We have the passion and enthusiasm that makes things happen. And we also have a commitment from patient advocacy groups. We have political documents which have been posted in the chat by Emma, the Prague Declaration, the guidelines, the recommendations. Why is it not yet happening? What else do we need to do as a community? And I would like to go first to Zanfina and then Kanika.
Thank you, Magdalena. I think we've shown different paths that it works, it's successful, but I think education is key. It's not educating only patients, but educating clinicians as well. Those who are at the forefront, especially general practitioners, knowing about the FH, because those are the first open door to identify patients with high cholesterol levels. Thank you.
Thank you so much, Zanfina. Kanika.
Yes, thank you. I think, I'd like to follow on from that by saying that I think at the very least, if we perform lipid tests, measure LDL-C across all age groups, so that we can effectively identify FH in all the different age groups. So and especially in childhood, so we can enable prevention-based activities.
Thank you. Professor Wigman.
having such brilliant researchers like Kanika and Samvina doing important research on FH, that helps. And it will help that you, Magda, will come to Amsterdam, because the Netherlands was far ahead, but slowly becomes behind. Another problem what we find in the Netherlands is that they start early, but that they don't continue if they were referred to GPs. And that worries me. So we have a lot to do in the Netherlands.
And with help of young ambassadors like
Indy
Danique,
and
Indy,
Danique,
yes, I
fantastic.
think this is where the future lies. So thank you,
Absolutely.
Albert. Ivan and Gergely come next. Ivan, over to you.
Well, only several thoughts or words. Awareness, 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 networking, 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 and I will paraphrase, just do it.
Wonderful. And I will take that next to the 5 golden rules by Albert Wigman. I
Just
will
do
keep
it.
those.
It's a sixth rule, just do it.
Gergely, what else do we need to do?
Yeah,
Or is it enough?
So we do have the numbers, the figures, the ways, and the hows. We just need to get states and decision makers understand and be aware of that, and to implement that. Yeah.
Wonderful. And with that, I would like to take my last opportunity, Tinkara, to share a little bit more information about the upcoming webinars. But before everyone starts registering, Emma will pop in as well a link to the website where you can register to the upcoming webinars. I wanted to say a huge thank you to those wonderful panelists, a huge thank you for everyone who joined us on this webinar. I hope you are inspired. I hope you are empowered, because ultimately what we're trying to achieve with FH Europe community is to shift from cardiovascular disease as a result of FH and HoFH towards cardiovascular health, where policies are in place, where the knowledge prevails, and the next generation of affected individuals and families can live a really normal, happy, healthy life. On that note, I wanted to say thank you once again, everyone, and see you soon at the next webinar. Thank you.
Thank you.
Bye.
Thank you very much.